Good afternoon, everyone. Scratching my nose, it's been a long day, but it's really a tremendous honor for me to be able to introduce Dr. Cooley to talk about medical health issues. And I guess I should thank the American Academy of Pediatrics for funding his visit here. You know, I'll never forget dinner that we had with the First Lady where Dr. Cooley really crystallized my understanding of the medical home. But in terms of full disclosure, I should say that Mrs. Obama was actually sitting on the other side of the restaurant at the time. But it was a dinner with the First Lady. But I was really excited that Dr. Cooley agreed to come here and give this talk because I really do learn something when I think of myself as a general pediatrician every time that he talks. So Dr. Cooley is a developmental pediatrician. He also is an adjunct professor at Dartmouth. He's the chief medical officer of the Crotchet Mountain Foundation in Greenfield, New Hampshire. He's the medical director of the Center for Medical Home Improvement within the Crotchet Mountain Foundation. He has a wide variety of clinical interests, which are really of interest to this group, including Down syndrome, autism spectrum disorders, traumatic brain injury. More relevant to the talk today, he's the director of GOT Transition, which is the National Healthcare Transition Center, which I believe is funded by HRSA as well. And he's really won many, many awards, which if I listed them off, he wouldn't have any time to talk today. But of note, he's one of the directors award from the Retail Child Health Bureau of HRSA, which is really, I think, illustrates the high regard that he's held at a national level around how to improve care for the children and families get. So, Dr. Cooley?
It's a pleasure to be here. My plane from Charlotte to Nashville was canceled, as I learned at the airport, and so I had the opportunity actually to drive here from Charlotte, which was the second half of it was a beautiful drive into the mountains. And then when I spent a vacation here 2 years ago, a little bit earlier in the year, and I just recall all of the surrounding area. I liked bicycle, and we spent a good deal of time finding that it was at least as hilly as New Hampshire. But I'm delighted to be here. I've enjoyed my collaboration with the New England Genetics Group over the last couple of years as chair of their medical homework group, and also more recently being chair of the NCC's National Medical Homework Group, of which some of you may be participating in. I know Alex does. And it's my years working in, I changed this. So I have nothing to disclose. This kind of work still doesn't generate any extra income. So, and my interests in medical home really date back about 35 years or so. I had my start in pediatrics as a general pediatrician in Newport, New Hampshire, which is a small mill town of about 5,000 people. And I began to realize how frequently I had patients with rare conditions. Only one of each condition, but there were quite a number. The predictions by my colleagues in residency that primary care would be a boring undertaking of well children and diaper rashes proved false. And I kept a little notebook of I guess I would have to say interesting cases was the term I used at that time. I probably wouldn't use that language today. But, and it really became quite full. And I now recognize that was probably a registry of a type, certainly not electronic. But even more than this, it was really this event in my life, 27 years ago, the birth of my daughter Sarah with Down syndrome, that sort of catalyzed my interest in looking at the systems of care that individuals like Sarah were going to need in their lives. And this moment in time for a parent, and it's generically the moment when blood spot test comes back suspicious or when a variety of other things happen in the newborn period, is one in which they are usually still under the illusion that there is a system of care for their now child with special health care needs. And being partly inside that system, was able even then to recognize that the system was not quite complete 27 years ago, and it seems we're still working on it. But I decided that I wanted to spend some of my professional life looking at health systems, particularly as they pertain to the value of primary care and the necessity of high-quality specialty care, and the fact that they need to be in communication with one another for things to really work in a systematic way. And families need to be part of that communication. Sarah's grown up. She was married in 2008, and though she's had some eventful experiences with the healthcare system, she's a very accomplished young woman, and I can't claim any credit for having created some kind of a system that made that happen. But in any event, it did. So the brief collaboration between Alfred Nobel and Thomas Edison. I think that collaboration is sometimes a dangerous business. Sometimes we have assumptions that it will go smoothly, and it becomes more explosive than we anticipated it would. But nevertheless, it's collaboration that we need to be thinking about and talking about. So I'm going to talk a little bit about the family-centered medical home. I could talk at length about it, but I'll try to restrain myself. I'll talk a little bit about managing complexity, because we're really thinking about children and youth, young adults with very complex healthcare needs, and look at some of the integrated systems of care and accountable care organization ideas that are beginning to emerge, and try to touch on what some of the policy implications are for these. And I'll try to do that in time for everyone to get to the reception and cash bar and finish with your sitting still for a while. So care that isn't coordinated is fragmented. I mean, it can only be one or the other. If you feel that the care systems in which you're involved are not yet fully coordinated systems of care, then it's pretty certain that they are fragmented in one way or another. Medical home implementation moves forward, but remains sporadic. And you all, in many of your projects in the regional collaboratives, are asked to emphasize the medical home, to be thinking about the medical home. And I suspect that sometimes when you look around, you say, well, but where is the medical home? Where are these incredible practices that have care coordinators and registries and care plans and proactive care? And the answer is that they're not there yet. And this is, to some degree, an aspirational model, but it's towards this aspirational model that our planning needs to aspire, so that we're moving in that direction. Primary care comfort with complexity varies, but it improves with better communication and information exchange. Specialty clinics cannot do the job alone. I think as we increase the number of conditions for which screening occurs, as I listen around the edges of gatherings of specialists, hear concerns about their capacity to see all of these kids and to provide high-quality care. Your capacity to do that, I probably should say, so that you probably know what I'm talking about. And collaborating with providers in primary care is really an extension of that workforce if they have the information they need and understand the role that they can play in this process. Actions needed to promote both better care and better systems of care, and it's needed to target somewhat of a future context rather than just saying that because of the obstacles that exist today, we have to continue to do things in this fragmented manner. The National Medical Home Work Group that I mentioned is working to define necessary functions of a medical home. We're hoping that all of the regional collaboratives can come to some kind of common understanding. There are a fairly small number of national definitions that have been adopted around medical home, either in legislation or in policy. We're trying to define what coordinated co-management means and define the notion of locus of condition management. This is acknowledging the fact that a lot of the care, a lot of the hours of care of a child with complex needs is going to take place in the specialty setting. And as I'll try to make a point, that does not make that setting the medical home, but it may make it the locus of management for that condition. Examine effective models and tools for communication and co-management, and then consider means of tracking and measuring co-management practices. The family center medical home is both a place and a process of care. It is care that is comprehensive, planned, and coordinated. There are a variety of other things to put in front of that word. In addition, family-centered, culturally effective, etc. But comprehensive is one of the key words. Planned and coordinated, I think, are one of the key aspirations. And it can be recognized by its functionalities and adherence to widely accepted standards. This is a model that I've used in talking to pediatricians about medical home. And sometimes it's a slide in which the medical home, or the primary care model that I learned as a resident, is really the two parts on your left side of the screen: acute illness management and preventive care management. And that notebook full of kids that I was keeping track of, I had to try to fit into one of these two areas. I really didn't have this concept of chronic condition management or primary care in my practice, so that I had to extend well child visits to handle the complexities of a child with cerebral palsy, or I would deal with the chronic problems when they came in with acute exacerbations or presented in the emergency room. As we developed a more advanced model of primary care under the medical home brand, we began to think about a specific set of activities called chronic condition management. And this doesn't mean managing all of the aspects of a chronic condition, but those of which lend themselves to management at the primary care level. It may be communication with community-based organizations. It may be triaging acute episodes at the front line and then communicating with the specialists. It involves a registry, it involves care plans, it involves office visits that are specifically about the chronic condition, not about the 9-month checkup, not about the earache, but about sickle cell disease or about Down syndrome. And it involves explicit co-management with specialists, which I'll talk a little bit more about. Oops, I guess that gets bigger too. And this primary care medical home is well situated to be part of a better coordinated system because it sits on this horizontal axis of community supports in the middle of the family's community. And it also sits on the vertical axis of the healthcare system, if you want to think of it this way, in which you can communicate within the healthcare system better than these other community organizations can do. And it can provide longitudinality and continuity. We know that primary care medical homes get better results with respect to utilization, lower hospitalization rates, less emergency room use. There are quite a few studies of this, including one that we did a few years ago. Higher satisfaction, less worry, fewer school absences, better health status of the child for families receiving care in a pediatric medical home. So we know that general care is better. Both of these focused on children who had special health care needs. So I had the opportunity recently working with colleagues of yours in New England, working with a network of cardiac care centers around the country, 65 cardiac care centers that are trying to improve outcomes for children with hypoplastic left heart syndrome. And that's another rare and complex condition, not unlike some of the ones you're involved with. And it's made me think about the complexity theory ideas, and some of you may have heard of these. But problems can be simple, they can be complicated, and they can be complex. And if you get these mixed up in the way you try to solve a problem, you're probably not going to arrive at a very good solution. Simple problems are me cooking lasagna. although that's complicated in certain ways. Solved by following a recipe. Good recipes produce good results. The good results are consistent over time, and not much special expertise is required. And there are not a lot of simple problems in healthcare, but there are simple problems around us. Complicated problems require a higher level or a high level of expertise, and they're solved with a sequential linear process. So that putting a man on the moon is a very complicated process, but it's reasonably sequential, and it's a series of steps that have to unfold one following the other. Replication of success is expected. If you put a person on the moon once, you expect to be able to do it again. There's a reasonably high degree of certainty of outcomes. And complicated problems are solved better by having checklists of action steps. Did I do X? Did I do Y? Did I do Z? Check, check, check. Who needs to do what, when? And there are quite a few problems like this in healthcare. And we, I think, treat many of the problems that we deal with as complicated problems. I think, however, complex problems, processes are likely to be simultaneous, not linear. There's several things going on at the same time. They involve multiple systems, localities, entities. It's not all taking place in your shop. And expertise is necessary but not sufficient. Communication and coordination are critical. Treating complex problems as merely complicated increases the variability of outcomes. So if we don't recognize issues in this way, we're going to have less predictable outcomes. And in this case, instead of action steps, there's a checklist of communication steps that improve outcomes. So who needs to talk to whom, when, and who has talked to whom? Did you ever?
Yes, the example of this one. Yes. The complex problem.
Example for this one is a child diagnosed with any of the above on newborn screening. Public health systems involved, the local hospitals involved, the primary care systems involved, a distance specialty medical centers involved, and it's really the reason why I bring this kind of notion in front of you. It's really the kind of problems we're talking about. Caring for children with complex conditions is a complex process for the reasons I've identified, and it requires a team or teams, more likely, including, in my opinion, at the very least, the family, the specialty teams, not just the specialist physician, and the primary care medical home team. And communication and coordination are critical. Genetic and metabolic conditions, complex care, yes. So who manages the care of the child? Well, it depends on what part of that care you're talking about. It depends on when you're talking about. It depends on what else is going on. It depends a little bit on what the family's preferences are and what they're comfortable with. Who manages the care of the condition? Well, a lot of that's going to be in the hands of the specialist. This is a complex problem. It requires that expertise. So specialty clinic teams are going to be managing most of the care of the condition. Who coordinates that care? How many of you are in settings where there's somebody whose job title is care coordinator? Oh my goodness. Well, how many of you coordinate care?
All of us. For the reason that you just showed, that nobody else is assigned.
Right. And I think, and that may not be the right solution in some of your settings, but somebody needs to be championing that. And part of the reason for that is that there's somebody in that role in other settings. Every practice that we've worked with in primary care around medical home transformation now has an office staff person who has care coordinator written on their name tag. And they are the person that is trying to communicate with your clinic about the care of this child that's also in their practice. And they need to know who to call. Who's their counterpart? Who is their care coordination counterpart? And it may be somebody you identify. It may be a dietitian or nurse. It may be one of the providers. Who knows? But that individual needs to know who your individual is. And if they can communicate with one another, a lot can happen that frees up the providers to deal with that expanding workload. And who provides the medical home? How many of you feel that the special clinic provides the medical home? You can be honest, I don't mind. They're good here too. And the definitions of medical home, however, that are coming into play with insurance companies and with CMS and with the Affordable Care Act, say that if you are doing that, then you need to be providing all the immunizations, all of the well child care, and be ready to do the acute illness management, because medical home is a brand name for transformed primary care. I mean, you may be providing a lot of the care, but you're probably not providing comprehensive care. And it's one of the things that, in using that term in this environment or in others like this, that we need to be clear about what the definition of medical home is, and not be kind of making up our own definitions that are out of line with payment systems and other things that are rapidly evolving. Primary care, well, this is actually adapted from something we did with the pediatric cardiologist around hypoplastic left heart. I asked that room full of cardiology centers, well, who's the medical home? Should you be the medical home? And about 50% of them said yes, that they should be the medical home. And because primary care physicians are not equipped to be the medical home for infants that change this to metabolic disorders. They lack the desire, they lack the training, they don't understand the complex physiology. You could probably expand that list. Only a metabolic specialist team can understand the balance of dietary management and monitoring needed. Only a metabolic specialist team has the experience with the entire life course trajectory of a child with a metabolic disorder, including neurodevelopment, educational issues, and so on. On the other hand, and I did this in point and counterpoint with a friend and colleague who's a pediatric cardiologist at UCLA. So he presented that perspective, and I presented this one, that the primary care medical home knows the local landscape. They can be the frontline person. If you've got somebody who's had 3 years of pediatric residency training at the front line in a community 200 miles away from your medical center, why not make use of them? Why not give them the information they need to recognize an emergency for this particular child and to be able to deal with it effectively? Otherwise, they may deal with it as they see fit, or the family may call you, or they may go to the emergency room where someone even less prepared is going to be dealing with the problem. Understands the life course trajectory of the children in this family, in this community. And as I said, failure to actively engage primary care may increase variability of outcomes. Everyone works at the top of their license, given the tools and opportunity. So, I mentioned fragmented care as the alternative to coordinated care. Some of the elements that are needed to have a system that's coordinated are knowledge of who the team members are. The specialty team professionals only, is that the entire team for the care of this child? Well, it's already clear that that team isn't providing part of the medical home elements like immunizations and anticipatory guidance. The specialty team in the family, very often that is a coordination unit that's very important. A collaborative care team, and I've left the cardiology people alive here, but the cardiology, the specialist team, the metabolic or genetic specialty team, primary care medical home, and the family. And if this is the team, then the team makeup and roles need to be explicitly defined. And this is to say that the primary care medical home needs to know the scope of its responsibilities, which is not to make critical decisions in the management of this disease, but it is to be a resource and be available and being accessible on a 24/7 basis in the community. Team members need to know one another. Have any of you read Atul Gawande's book on Checklist Manifesto? Anybody? It's a fascinating book, and those who've read it can recognize the fact that I read it. But one of the things that he did as a study was to post some researchers outside the doors of operating rooms. And as the operating room team came out, they asked questions of the people who were participating in the operation. And one of the questions was, do you know the other people's names that were in the operating room on the team? No, they didn't. Do you know what all of their jobs are? And generally they weren't very good at producing that result either. And he initiated a process of a huddle literally over the patient at the beginning of the operation, where everyone introduces themselves and everyone shares one concern that they may have about the operation, or a piece of information that they may know about the patient, and says what their job is, or what they perceive their job to be. And the introduction of that process reduced operative complications by a significant percentage, and improved the outcomes. And it was a matter of the teams knowing one another. So if this team is going to work together, they need to know each other in some manner. It can be electronically, it can be on a conference call, but there has to be some mechanism for them to become acquainted. There needs to be transparency or clarity about who's coordinating with whom. We've talked about how there can be locuses of coordination in each of these areas. Though it may not be clearly defined, the specialty team has some people doing care coordination. The primary care medical home team, more and more, has someone identified with that responsibility. Many of these community resources have somebody whose job title has the word coordinator in it, and is anxious to interface with the other elements. There needs to be a good way to exchange information. And we all have great hopes for information technology and electronics, and I believe those hopes are generally well-founded, but we need to know ahead of that technology kind of what we're looking for in terms of communication. I believe that there needs to be a written care plan that has an iterative quality, meaning that it evolves with the care. It may have static elements that are sort of demographic, but it needs to be talking about what the next steps are, who's going to do them by when, and who's going to check and see that they were done by when. In many settings, that's a coordinator's role, to sort of oversee those care plans. There need to be timelines, and there needs to be a method of circulation. These are very granular things that need to be sort of tackled in order for this to work. There needs to be a portable medical summary. There are many people in the healthcare system that are looking for a 2 or 3 page thing about this very complicated patient. The emergency room would like to have a portable medical summary. The family, when they travel, would like to have a portable medical summary. Jim talked about transition and sickle cell disease. Those adult providers want a portable medical summary. They don't want 18 years of a medical record. They want to know in 2 or 3 pages what happened and where they are now. And they want fact sheets. They want that information. I think more than any other area, genetics and newborn screening has done a great job of beginning to develop those act sheets, which are exactly what this is talking about. It's important that they have critical information for families, for primary care, and other local healthcare systems like ERs, and that they talk about what's an emergency and what to do. That there's response plans for critical events that are the right steps, so that vomiting in a child with a metabolic disorder is not the same thing as vomiting in a baby who you think might have gastroenteritis. And if you think it's gastroenteritis, you're going to make a big mistake. So those things need to be red flagged or very easy present information. So in these new systems, all elements have a defined role to play. And right now, we have a lot of implicit roles, if you think about it. We don't do a very good job of explaining to the family what their role is going to be in kind of explicit terms. And we don't do a very good job of clarifying the specialty role and the community-based primary care role in an explicit way. And if we're not explicit about it, they're going to get defined in ways that we didn't want them to be defined, or that aren't appropriate, or that are putting too much responsibility in the hands, for example, of primary care. So we need to be clear. All elements have a shared stake in the outcomes. There's a shared clinical risk. There's going to be a shared financial risk. All elements are connected by reliable systems of communication and information exchange. Some of these new systems, how many of you are in what you would call an integrated system of care? One organization that has primary care, specialty care, hospital care. Anybody in that kind of a setting? There are some, I'm sure, in this region, and there's some in other parts of the country. You know, one thinks of Geisinger or Kaiser or other entities like that. But those integrated systems are beginning to look harder at what I've just been talking about, assuring this kind of explicit communication. And they're in a position to have integration of care driven by policy and a supportive infrastructure, because everybody's kind of using the same electronic health record, working within the same payment structure, and the relationships can become more well defined. I would say that some of those systems that have the potential of being integrated in this way are not yet so, but they are all thinking about it, believe me. And they're thinking about it partly because they're seeing these words every time you turn around. Accountable care organization. Or something that is, in my opinion, probably not yet in existence. This has gotten a lot of attention as though it's sort of around every street corner. But in this case, not all the elements are members of the same parent organization necessarily, and they're more economically independent. There's a reasonable example in the Medicaid system in Ohio around Partners for Kids, which are children with special health care needs on Medicaid, and it's an ACO-like model managed by Nationwide Children's Hospital and a network that they don't own of primary care providers in their catchment area. In this case, integration and coordination is driven by incentives. The notion is that there'll be bundled payments. I mean, think about a bundled payment for the entire care process for a child diagnosed through newborn screening with sickle cell disease. It's a little hard to imagine what that number would be for that payment. But then the payment is divided among the hospital care, among the specialty outpatient care, among the formula providers and the primary care providers involved in the care. And they are all incentivized for the cost of the entire care to be as low as possible, so that that bundle goes as far as possible. That's, I have a little problem with the system that's so dependent upon cost controls and not quite so obviously interested in quality, but it is sort of the reality out there. And it's highly dependent upon effective care coordination capacity. Accountable care organizations are going to see to it, or you're going to see to it, there's somebody who has care coordination on their badge, care coordinator on their badge, when you get into that game, because without that, it's going to be very difficult to survive this sort of bundle payment arrangements. And this is just, I'm almost finished. This is just, in one of the worlds I work in rehabilitation of children with traumatic brain injury, children and adults for that matter. We at Cratchit Mountain are situated right here and a little bit here, providing acute rehab and some longer-term care for people following brain injuries. But there's the emergency room, intensive care surgery, intensive care and surgery, acute hospital care. This is all in the hospital, rehab. These green line are services in the community, and down here is the follow-up after hospitalization with specialists. And at least in conceptualizing a model like this, the primary care medical home is in a fairly critical position. And a traumatic brain injury were an episode of care. If there was going to be a single payment for everything in this system that person is going to need for their care, and that's not an unrealistic concept. It's the kind of thing that people are talking about. Then all of these entities will contract with an accountable care organization, which will decide how to divide up that bundle of payments to achieve the best outcome for a patient who's passing through this system. And I think we'll see more and more models like that. So finishing up, I guess, and some of the policy and planning implications I'll leave to you to think about in this region. You know the region far better than I do. We're hoping that the National Medical Home Work Group will soon have a publishable white paper on the kind of concepts that we've just been talking about. I think we need to use these regional collaboratives to identify effective models of coordinated care for children with heritable disorders. Jim talked about looking around for models for sickle cell disease, looking around for the tools, really. You know, what does a good care plan look like that can be passed back and forth between family and primary care and specialty care? Who's trying that out? Advocate for improved systems of communication and information exchange. Totally interoperable electronic health records would be a big plus, but we're not anywhere near there yet in those settings. But email, fax, patient-derived websites or portals actively support the role of the primary care medical home in the long-term management of children with genetic conditions. I think that you don't need to wait around for all those practices to become transformed medical homes. That's going to take a while. But you may be able to infect them with some medical home responsibilities through the way that you communicate, and the way you define what you expect their role to be, rather than looking for people who seem the most energetic and willing, provide the kind of information they need to function well in that role, and have a dialogue that's bi-directional, not one-way communication. And promote the development of registries capable of tracking both individuals and populations. And I already know you're thinking about that. That's it. Thank you very much. If you're happy with questions. Okay, and first of all, think of medical home as a new brand name for primary care. It's none other than primary care. It's not a cloud of services. It is the primary care office. You only need a new brand name for something when it isn't working as well as it should. And there are many countries in the world that don't need the medical home concept because they already have primary care at the center of their healthcare systems, and we don't. We have kind of willy-nilly, go to the specialist, go to the primary care, go to the hospital. People, and I think I'm not saying we should eliminate all of that kind of choice, but so Exeter Pediatrics has been working on its medical home model in New Hampshire since we started working with it in 1995. Our first medical home grant for HRSA was in 1995 or 6. And we've been working on it ever since. It's a long time coming as far as getting some traction. But so it is a practice with 6 pediatricians, 6 nurse practitioners, about 25,000 patients, and they have 2 full-time care coordinators. One's a nurse and one's a social worker. They have a registry of all the children who have special health care needs in the practice. There's several thousand, as you can imagine. And they have them stratified by severity in the registry. So they use a scale from 1 to 10. It's, I think, a little bit complicated, but they like it. And everybody who has a complexity scale of 7 or above is on the caseload of the care coordinators. And they they all have written care plans in their medical record that are updated. And the care coordinator's job, among other things, is to track those care plans. she has, one of the care coordinators has visits with patients when they come in for visits. They come in for a chronic condition management visit. Part of that visit is with the care coordinator. You know, if you got all your benefits straight, how are things at school? But, you know, when did you go to the specialist? The other thing that Exeter does is do a number of others. There's a great medical home practice in Chapel Hill, Jennifer Lale, Chapel Hill Pediatrics is one we've worked with for a long time. They have every chronic condition visit has a pre-visit call from the care coordinator. So she calls the patient a week before, not just to remind them that they have an appointment, but has a conversation with them about, have you seen the specialist lately, X, Y, and Z. And if there needs to be lab work at the visit, she orders the lab work, so that instead of ordering it during the visit, who trains her? Or him? Most of them are trained on the job. By the primary care physician saying that we need you to do these things. There aren't any curriculum. We're working on a sort of primary care-based care coordination curriculum. We're working on it as a career path for nurses in primary care. But it's not kind of there yet.
I guess the thing that I react to, and I suspect some of the others in the room react to, about this notion of the medical home being a primary care physician setting, is that in some of these patients, and I'm just talking about genetic metabolic primary patients who have chronic need for specialty care, we tend to be the folks they call regularly and not their primary care docs. And often their primary care docs are happy to have it that way. And to some degree we probably are too, for the care purposes. You know, it becomes an issue of, don't take this the wrong way, ownership. I feel as if the primary care physician is the medical home, do I have ownership of this person that I'm so invested in?
Yeah, those are important questions, and part of the tension, I think, is between the present and the future. I mean, that's still not an ideal system that you're describing.
It's actually only not ideal to the degree that our communication is not ideal, and it's usually not ideal, but theoretically it could be perfect, as well as your other theoretical. I mean, the problem with the primary care medical home model, as I perceive it, is that the person that's driving the bus for the specialty patient is not the one that is ideally trained to do that.
Meaning who?
The primary care physician.
Well,
in a child with methylmalonic acidemia, who,
I'm trying to be clear that the primary care physician is not going to be driving the bus about the chronic condition. The specialist is very definitely going to be doing that. But
so is he a medical home?
No.
Okay.
Not unless there are some examples of specialty-based medical homes, but they provide all of the care that child needs.
And I don't. You're absolutely right.
So,
and that's why that shared care is so critical.
Right.
I think.
Well, I think that one of the things to be careful about in talking about ownership, for example, is whether or not you think you may have ownership, or you think that they always call you when they have a problem, but you don't always know those who didn't call you when they had a problem. Families still make decisions on Saturday night based on all sorts of factors.
They might meet before they get the primary care done.
Not necessarily, I would think.
No, the DR.
Don't you say then go to your PCP and check it out first? I mean, that's on a Saturday.
He's a nice guy.
That's never happened. They
No.
go to the emergency room, and I call the emergency room, and I tell the physician in the emergency room, here's this patient, and here are my concerns, and I know this person.
But a 9 to 5.
So,
9 to 5.
Well,
Well, I mean, like, we use the process. We do. But you can't.
I guess it's so culturally independent, it's
It's dependent on a lot of unpredictable things, and if you want the outcomes to become more predictable, then those instructions have to be explicit.
And what happens if your special patient goes to the emergency room and the emergency room says, we don't deal with this?
Our patients have autism. They go to the emergency room and they're told, we don't treat autism. The ER doc last week said, we'll pray for you. It's helpful.
Well, I think that
And then your examples of medical home are wonderful, and we are working hard in our system for pediatric and medical homes. But what you described with care coordinators was you described a multidisciplinary, in other words, you have multiple pediatricians, you have nurse practitioners, you have enough revenue to support a care coordinator in that practice. What do you do with the rural practice who has maybe 3 pediatricians and is the only pediatrician group in the county? So where there is not the revenue coming in because 67% of the patients seen are on Medicaid. And they have just, in our state, decreased Medicaid payments by 7% to all physicians. So, we are working hard to look at producing medical homes for our kids. But it really is a major problem.
right. Well, it hasn't had a payment system that supports it, and I think that's been one of the main obstacles. But small rural practices do care coordination as well. They don't always have the person to do it. But,
So Carl, I want you, when we were doing our long-term follow-up planning, we had come up with a proposed term, and I want you to react to it. We had said, used the word a care plan leader, instead of defining whatever, and a co-management concept. So we had said that whatever disease we were managing, we are the care plan leaders for that, and whatever other GI or other. So what do you think about that term? Does that make the...
I think that concept certainly is genuinely important, so that for this complex metabolic disorder, the captain of that ship or team that's captaining that ship needs to be explicitly identified. And everybody who's involved in care needs to know that. It's very complicated, complex, and it's also in some ways very simple in that it's about making explicit what we think it is that we do wherever you were situated. But I think that the white paper we're talking about is using the term locus of management, which is to say that locus can be here for one condition. Maybe the child has a congenital heart defect as well. It's got the cardiology team involved, and maybe that locus changes over the life of that child when things stabilize. Certain conditions have that kind of a.
I think we'll take one more. Yeah, I remember reading an article where when the job description for a care coordinator was announced, it was so complex that nobody took the job. and also, I'm pretty sure even a good care coordinator's short-term memory will be extremely stretched. So they themselves have to keep a checklist themselves of what actually they are supposed to do. It is so complex. So do you have any alternate model other than the care coordinator model for managing complexity of these diseases?
Well, the care needs to be coordinated in some way or it's fragmented. So You can call them a navigator, you can call them something else. We haven't had any trouble with people liking this job. Nurses working in primary care feel that they're finally working at the top of their license, doing care coordination rather than weighing patients and putting them in the rooms. They are very enthusiastic about it. I think some of the generic job descriptions that are out there are just templates. They're just sort of ideas. They don't have to be that complicated list of tasks. And I think we're also putting on the shoulders of those who coordinate care some tasks that will be more electronically managed in the future, tracking lab tests and tracking referrals and things that can be done electronically that are now having to be done sort of by hand. But I would just encourage you to aspire to influence change around you rather than say, well, I don't, it's just the way it is. We can't do anything about it. There are parts of it that you can't change right away, but there are lots of parts of it that you can touch.
Great.
Thank you.
Thank you, Dr. Cooley, and appreciate the talk. Obviously, a lot of discussion, a lot of interest. I think your airplane troubles caused you not to be here when I mentioned earlier today, but medical home is going to be a major focus of our region for the next cycle, so we look forward to working with you. And thank each of you for your participation today. I would invite you all to the reception next door for the next